approach. But the idea here is that the future of menin inhibitors is not in the relapse refractory setting. The future of menin inhibitors is in the upfront setting. And so this project of all these sponsors and all these trials and testing them in the relapse refractory setting is already bearing fruit in, and again, we haven't even talked about the other drugs. We're just talking about revumenib right now, already bearing fruit in moving this up to upfront. Revumenib was, there was data that was presented actually at, I believe it was EHA, that the Beat AML consortium, 24 patients upfront AML treated with azacitidine venetoclax, which is the standard of care for unfit patients with AML, with revumenib, with an over 95% response rate, over 90% MRD negative rate in patients who have upfront NPM1 and KMT2A rearranged AML. In addition to that, we have phase 1 studies where they're combining revumenib with chemotherapy. There's phase 1 studies where other menin inhibitors, including Kura's ziftomenib, is being combined with chemotherapy upfront and with non-intensive therapy azacitidine and venetoclax upfront. So what I think is the broader goal of the leukemia community here is understanding that in this high risk, we're talking only about KMT2A at the moment. I'll go into NPM1 in a second. In the KMT2A rearranged acute leukemias, the outcomes long term are so poor that we need to get these drugs upfront, get patients to allogeneic stem cell transplant. All patients with KMT2A rearranged acute leukemias who are eligible for allogeneic stem cell transplants, so usually under 75 and in good physical shape, should get transplanted, even if they don't have a full match. So that might be meaning using a mismatched donor or an umbilical cord unit, should be transplanted because of the risk of relapse being so high. So the idea here is being able to use this upfront and actually being potentially able to use it in maintenance, although those data that we will see from the studies which allow, including the Augment study, which allows using revumenib in maintenance, will take years to understand if it's actually efficacious or not. Now, that's KMT2A. NPM1 is complicated. So NPM1, for any viewers and any of you here who are familiar with the clinical management of AML, NPM1 is a favorable finding in both the ELN 2022 risk stratification for fit patients and the new recently published ELN 2024 risk stratification for non-intensive patients, which NPM1 exists on both as a favorable finding. But what we know about NPM1 mutations in AML is that it's a quite heterogeneous mutation. In fact, if you take 100 patients with NPM1 mutated AML, roughly 50% will have a favorable outcome and 50% will not. Now, it's a favorable mutation, so it's kind of confusing to speak about it in those terms, but I think it's helpful to conceptualize it because it is, because it's a favorable mutation, meaning that when it's there, in the absence of FLT3 ITD, for example, or P53, which is usually not present, but if it were, it would not be favorable. It is considered favorable no matter what. However, co-mutations, so that means other somatic mutations that are leukemia drivers that can occur, DNMT3A, FLT3 ITD, for example, that can make the risk worse, TP53. Other adverse cytogenetic findings, monosomies, complex karyotypes, for example, and there's a specific subtype of NPM1 within the mutation itself. They're called type A, type B, and type D. If you have a type A, type B, or type D NPM1 mutation, those are more favorable than non-type ABD. So we know that NPM1 is quite a heterogeneous disease, and if you take a look, if you were able to stratify favorable NPM1s versus unfavorable NPM1s, you would find that the favorable NPM1s, we probably don't need to change the standard of care much. Those patients do well. We're always wanting to do better. And there's actually a great article in Blood that came out about 2 weeks ago about two clinical trials in Europe, the AML-15 and AML-17, which looked at NPM1 mutations and sort of ways to think about the genetic background and how the outcomes are and whether there's benefit to intensifying therapy. And actually, we're not going to speak too much about NPM1 today on this piece, but the answer was yes. The standard of care may be changed for NPM1 mutated AML on a separate uh, in a separate way. But as far as the purposes of this conversation, menin inhibitors, which also work for NPM1 mutated AML, keep in mind, KMT2A rearrangements can occur in all acute leukemias. NPM1 is only in AML. Menin inhibitors are probably not going to be moving the needle that much for the favorable NPM1s. So in intensively treated patients, whether you're getting 7+3 or flag ida go, 7+3 and go, these are all reasonable intensive inductions for NPM1 mutated AML. It is not clear who should get what, and this opens up Pandora's box about how to think about it. So that's TBD. But for unfit patients, the standard approach of HMA-ven, aza-ven, decitabine-ven for NPM1 mutated AML. Again, I told you guys NPM1 for as long as we've known about aza-ven has been known as a favorable mutation in patients who have extremely long favorable outcomes after HMA-ven. It is not clear which patients are going to benefit from menin inhibition in upfront AML in this context. However, in relapse refractory NPM1, we do have a lot of data in revumenib and also in ziftomenib, which is Kura's menin inhibitor, of, again, response rates, composite response rates that are in the 30% range and overall response rates that are in the 50% range. So sort of the long answer to your question, Jan, is yes, we have response rates that are in the 25 to 40% range for composite CRs, overall responses that are in the 50 to 60, maybe even 70%, and MRD clearance or MRD negativity in the remissions of anywhere between 60 and 80%, which is tremendous and shows the deep effectiveness of these drugs. And then lastly, to your point, the durability. Again, right now we're looking at these drugs in the relapse refractory setting. Long term, I think we're thinking about these drugs in the upfront setting. So for right now, the durability matters. But in the long term, if we're using these drugs mostly in the upfront, the durability becomes less important. And instead of talking about durability in months range, we'd be talking about survival in the many, many, many years range. And in fact, if we do this correctly, we wouldn't even be meeting median overall survival in these patients, in the fit patients. So right now, the durability looks like something in this for median duration of response. It's something in the 6 to 9 month range, which is not amazing, but it's good enough. And points out the fact of why the ultimate destination of these drugs is not in the relapse refractory setting. It can be helpful. It's a tool in our arsenal, but these leukemia patients ultimately will relapse, most of them, despite menin inhibition. So we have to be very thoughtful and creative about our clinical trials and crafting protocols moving forward.
Thank you so much for that thorough response. Now, as all therapies and medications in oncology, are there any mechanisms of resistance that you can talk about? And if and how these mechanisms of resistance are being addressed in present and or future clinical trials?
Sure. So I actually will take this opportunity to talk about two things. One is your question on mechanisms of resistance and also the tolerability and safety. So the mechanisms of resistance are not entirely clear. We have two data points to go on. One is a Nature article, I believe it was in March 23, from the investigators, including the team at MSK, Dr. Stein, from the revumenib clinical trials, where they were showing on-target resistance mutations. So basically, you actually have resistance in the menin protein that render binding inadequate or incapable or loose, and therefore you actually are not inhibiting menin. And they saw a fair amount of this over time. So initially, there was not that much of the menin on-target mutations, resistance mutations, and then over time, these develop. Now, when the second data point we have is the Kura group, the ziftomenib compound, they report in their public releases less on-target resistance. The theory might be that it's binding more strongly. Ziftomenib is once daily dosing, revumenib is twice daily dosing. There may be a difference there in the pharmacokinetics and pharmacodynamics. They did still see some mutations, but it seems, again, for what's being reported, that there was less on-target resistance. I have to say, there's a Nature article on, and we can see exactly what was presented. The other one is in a slide deck and a press release So I would say, without having any bias, we just should wait till we have publications on both so we can understand better about what this means. I will say, to your other question, Jan, about how we figure out what to do with on target resistance. There's a couple ways you can go. So we'll take a lesson from our solid tumor colleagues. In EGFR inhibition for EGFR positive non-small cell lung cancer, obviously they addressed EGFR mutations with osimertinib and other EGFR inhibitors that are quite effective in resistance mutations. And same thing in CML with the BCR-ABL TKIs. We have two now that are targeting the common resistance mutation T315I. We have ponatinib and we have asciminib. So we have ways when the on-target resistance that occurs in small molecule inhibitors, we have ways of developing drugs that either resist this or counteract this. Again, osimertinib, ponatinib, asciminib. But we also have small molecule inhibitors like gilteritinib and midostaurin and quizartinib, which are FLT3 inhibitors, and enasidenib and olutasidenib, and ivosidenib, which are IDH2 and IDH1 inhibitors. And in these situations, that last category of drugs, the small molecule inhibitors, they don't clearly develop on target mutations. So we don't have drugs that address the patients who become resistant to FLT3 or IDH inhibitors. We don't have drugs that counteract those mutations, because it's not clear entirely that the mechanisms of resistance are on target in that setting. So there's a lot that needs to be discovered and learned regarding menin inhibitors and on-target resistance. However, if it's as clear as the investigators on the revumenib clinical trial suggest in their paper in Nature, then probably there will be a way to develop menin inhibitors in the future that actually can deal with the on-target mutations. And my guess is that it looks to be the case. Now, the stronger the binding of the menin inhibitor to menin, you'd think the less likely there would be on-target mutations. But I suspect that there will be an open window for this to be developed and investigated. And this is moving all really quickly. And we have some excellent minds working on this, some great institutions, my institution, Weill Cornell Medicine, Dana-Farber, MSK, MD Anderson, among many others, University of North Carolina. I don't want to name drop everybody, but there's a lot of people that are working on these. So I do believe that these will be addressed. And I think, to your question, I think that the resistance mutations that might occur, I think there's a possibility that we can target these. Now, the other things I wanted to address in this subject or in this topic is safety and tolerability. So one thing that's been awesome to understand so far about menin inhibitors, if you look at all 6 companies, sponsors that are developing menin inhibitors, Biomea, Kura, Syndax, J&J, Sumitomo, Daiichi, there have been over 200 patients that have been dosed with menin inhibitors. So we are getting a very clear, very quick understanding. Actually, it's been a lot more than 200, but let's just say 250 plus. We are getting a very clear understanding of the landscape and type of class-specific side effects that can occur. Now, not surprising, there's some, drug-drug interactions, there's CYP inhibition, things like that can occur with small molecule inhibitors, QTC prolongation. That's not really class-specific. That's drugs that's sort of drug-specific and depends on how the compound works. But the class-specific, unique, novel side effect is differentiation syndrome. So differentiation syndrome, without delving too much into this, which can be its own topic, essentially is a hyperinflammatory response that occurs when leukemia cells, which have a differentiation block, have their differentiation block removed, and all those cells proceed to normal. That is a very inflammatory process. It can lead to fluid overload, edema, fever, shortness of breath, pulmonary infiltrates, et cetera, et cetera. And if not treated, patients can die. Now, the good news with this is that we now know of like this being a class specific side effect, and you can address it. You can cytoreduce with either chemotherapy, hydria. You can give immunosuppressants like steroids, like dexamethasone. Even give chemotherapy like cytarabine if the white count's rising. Once you are having a high index of suspicion, it's actually quite easy, in my opinion, to treat. However, it can be confusing because it can look like fluid overload, it can look like sepsis. So you just have to have a high index of suspicion.
Thank you so much. Very, very thorough explanation. So, you did speak about the two most common mutations and rearrangement. Seeing where the field is headed, are there additional biomarkers that are being reviewed slash say that could be useful in predicting response to menin inhibitors in AML? And if so, could you please touch upon that?
Yes. So right now, if we look at again, this applies in KMT2A rearrangements to ALL, but we're mostly talking about AML here. In if we assume that about 30% of AML is NPM1 mutated and mutually exclusively about 5 to 7% have KMT2A rearrangements, that roughly is about 35%. There are expectations that as much as 50% of AML patients might be eligible for these menin inhibitors and might benefit from these menin inhibitors. And to your point about biomarkers, there's HOXA and MEIS1 expression that you can check on. This is experimental at the moment, but that you can check for patients that can predict response to menin inhibitors in patients who don't classically have a KMT2A rearrangement or an NPM1 mutation. So right now that's experimental and in its infancy, but we expect that can add about 10%. And then the last subgroup that's worth noting, especially in younger patients, is NUP98 rearrangements. That's another menin inhibitor sensitive rearrangement mutation that is actually very common. I wouldn't say very common. It's more common in younger patients with AML, including pediatric patients with AML. In fact, in revumenib, they published data or released data at ASH and then updated it on a trial called that has an acronym SAVE, which is oral decitabine, venetoclax, and revumenib in relapse refractory NUP98 rearranged, KMT2A rearranged, or NPM1 mutated AML. And they had, even though in the heavily pretreated, ill population, all 9 of their patients had responded to the combination. So NUP98 rearrangements are also about a few percent, maybe 1-2% of AML, and that also brings the total to close to 50%. So the long and short of it is, yes, we believe that there's probably about 50% of AML patients that could benefit from menin inhibitors. And I have to say, I based on that, I think to sort of conclude on this discussion, I think that takes us to sort of the end of small molecule inhibitors in AML. I don't believe after FLT3, after IDH1 and 2, and after menin inhibitors that there really is an appetite, and that you can look around, you're not going to see much for small molecule inhibition, specifically mutation specific inhibition in AML. There are RAS mutations in AML, and there's the group in the Anderson is actually looking at RAS inhibition in AML, but the early results have not been tremendously exciting. I think the field is going to shift from a small molecule approach, which has been the better part of the last decade, to immune-based approaches, NK cell engagers, NK CAR, regular CAR, antibody drug conjugates. These are going to be the new frontier of novel therapies, but we still have so long to go before we actually change the standard of care with menin inhibitors. It's just I'm already taking a step forward 5-10 years, but that's assuming what I'm saying is going to come to fruition. I might be called an optimist and see things glass half full, but if you review the literature, you probably would agree. But anyway, I think this sort of puts the cherry on top to about 15 years of research, taking us from the actually probably longer than that, from the mapping of the human genome in 2003 to 21 years later, where we have in AML we have 7 small molecule inhibitors and many more in development. It is quite an exciting time.
Thank you for really highlighting that in its very thorough aspect. Now, with every therapy, there is side effects. What are your thoughts on the potential long-term effects or toxicities of menin inhibitors, and what do you think still needs to be addressed moving forward in the field? Thank you.
So the really nice thing about non-traditional chemotherapy, so small molecule inhibitors, for example, monoclonal antibodies that don't have payloads, they are not going to be genotoxic. So we don't have to worry about genotoxic and effects that could actually lead to bone marrow failure, like you can have from actually giving chemotherapy in the first place. But it's a good question because we don't know long term what altering um, the landscape by inhibiting menin, which is an important uh, which is important for human hematopoiesis. The early data, these drugs have been in trial for several years. The early data suggests that there are not long term effects, especially because patients are not going to be on them for that long. You know, the ideal situation in my world would be they get started with intensive chemotherapy or HMA, then they go on that with a menin inhibitor, and then at some point they come off of it. It's not. I don't think it's. I don't love the idea of lifelong therapy for cancer. It kind of defeats the purpose in my book. And you can see that model in CML, where about 30 to 50% of patients can be functionally cured at 5 years by a treatment-free period. So I think that we're not in a perfect world, patients are going to be coming off the drug at 2 years after a maintenance period. So I think your question is valid and it's a good question. Because of the fact that it's a small molecule inhibitor, I am pretty optimistic that there will not be unexpected long-term effects.
Great. Thank you so much. Now, the field of epigenetics is a really growing and thriving field. How do you see the
Yes.
field of epigenetics interplay with menin inhibitors and contribute to the evolution of the AML field over the next 10 years or so?
So epigenetics and the idea that that there's things that happen to our DNA that are outside of mutations, the actual genes themselves. Hypermethylation is a classical epigenetic phenomenon that has been widely described in cancers, whereby you silence tumor suppressor genes and you enhance transcription of oncogenes, shifting the delicate balance to pro-oncogenic. Um, I think that one of the big winners of epigenetic science as it pertains to oncology were the development of hypomethylating agents. Now, listen, I understand decitabine and azacitidine were not developed recently; they were developed in the '60s. These are not new drugs. However, their application recently is based on the understanding that many patient samples initially we're looking at these patient samples um, demonstrated hypermethylated phenotypes and therefore DNA methyltransferase inhibitors make a lot of sense. Also, HDAC inhibitors. Although I understand and agree that there will be continued research in all areas, including in epigenetics, to better understand cancer and cancer development. And we have this is coming into fruition right now, and as it pertains to clonal hematopoiesis. So, again, without going on too much of a tangent here, I'll just briefly say that the common mutations in clonal hematopoiesis, DNMT3A, TET2, ASXL1, these are mutations that alter the epigenome. And we are currently understanding at a deep, deep level about how to potentially reverse this by high doses of vitamin C, by inhibiting certain cytokines, like using canakinumab, a monoclonal antibody against IL-1. These are things that are currently being investigated. So there is no shortage of research into epigenetic pathways in cancer biology. As it pertains to menin inhibitors, I'm not sure I can quite make the connection, but for sure, as far as pre-AML, like clonal cytopenias of undetermined significance, clonal hematopoiesis, and also in treatment of a backbone therapy of an AML, HMA. Of course, epigenetics has played a big role.
Thank you so much. Now, you briefly touched upon this, but this is kind of a very good segue to combine the two, the future. We are now at an advent, and one would argue, the renaissance of oncology. We have novel immunotherapeutic agents, bispecifics, checkpoint inhibitors, et cetera, et cetera. Where do you view menin inhibitors in the hierarchy and the landscape in the future? And what patient populations do you feel would most benefit from? Is it newly diagnosed or relapse refractory? I realize this is kind of a loaded question, but interested in what your insight is into the future.
I mean, currently it is without a doubt the top pipeline drug in development. There isn't anything that comes close, especially if not only for the fact that it sort of may pertain to 50% of patients with AML. That is a massive number. That's 10,000 patients per year. The incidence is 20,000 patients per year with AML in the US. The prevalence is in over 100,000. So these are pretty huge numbers. Now, to your point, I do believe these drugs will be and continually be available in relapse refractory, but I truly believe, especially in KMT2A and sort of this unfavorable, which I realize is very nebulous at the moment, NPM1 category should be standard of care and upfront. So that is probably about half of NPM1 patients and all the KMT2A rearranged patients, NUP98 rearranged patients, and then this possible hopeful, ability that currently is experimental, but of HOXA and MEIS1 expression to understand which patients are likely to benefit from menin inhibitors and having an assay to do that and predict.
Thank you, Dr. Kana, for that wonderful synopsis that you have. I'll be now passing the mic to Harshita, who will moderate our quick Q&A section.
Sure.
Thank you, Dr. Kana.
You're welcome.
Now, behind every person with a white coat, there is a story and a mission for why they pursued this journey as a doctor and this career. Can you tell us more about yours?
Sure. When I was growing up, I never actually had any interest in the field of medicine in particular. I love science, and I actually was dead set on pursuing a career as a meteorologist. I was going to get a PhD in atmospheric sciences. I had that all set up to go, and then one day I shadowed a meteorologist at the National Weather Service office on Eastern Long Island, and found the work to be not as exciting as I had imagined and I had thought. And it caused me at a very young age, I was only 17 at the time, to sort of reevaluate my this was as I was a junior in high school, to reevaluate my future career prospects and decisions. And even though I truly love learning about the human body, I never considered myself like a candidate to be able to go to medical school. And I think mostly it was just sort of lack of self-confidence at that moment I said, I've always been interested in this. I want to pursue this. And I thought it was amazing to be able to apply a deep understanding and knowledge of something like the human body to patients and people, and making them feel better and diagnosing medical conditions. I never at that point considered cancer, and certainly not leukemia, but that was my initial sort of foray. And then, over time, I had always been driven towards, I was always fascinated by leukemia. Maybe subconsciously this is the case because when I was 3, I was diagnosed with a blood condition called ITP after a viral infection, benign, and I was fine within a few weeks after some steroids. But I imagine there was some imprinting that happened during my pediatric hematology visits, and the fear that my parents had that maybe I didn't realize and was there subconsciously in the background. But I was always gravitating towards hematology oncology in college, in medical school when I eventually got into medical school. And yeah, I sort of kept gravitating towards it. I love the fact it's fast paced. I love the fact that there's so much interesting research happening, and I felt like it's a challenging field with a lot of important discoveries to be made, and that's what sort of drove me towards it.
a question that I have is following up on it. So you have the perspective of that of a patient. Can you expand how that has influenced your journey into medicine and how that personal experience has contributed to your approach to patient care?
So I think being too young of an age to really remember anything, I think it's hard to really reflect on that other than to say that I remember there probably was a lot of fear that my parents had at the time. But I will say that I've had family members that are patients. My dad had lymphoma. Thankfully, he's in remission. I've had grandparents with pancreatic cancer and colon cancer and prostate cancer. So I've been involved and been present for visits with other oncologists, and I have been able to see the compassion and clear communication skills that oncologists, not all oncologists, but many great oncologists tend to have. And I think that that plus really good mentors throughout my training have really honed my interest in what I'm doing now, but also in my ability to understand the patient journey, communicate well with patients and families, and have tremendous compassion for the difficulties that these patients and their families are experiencing, which includes obviously the medical, but also familial, psychosocial, financial burdens, et cetera. And it's not easy. And I haven't been doing this that long, but I have unfortunately tremendous experience in unfortunate situations with patients who have been burdened in many ways with these diagnoses. And so I think those things have absolutely sort of guided my path to where I am now.
Thank you, Doctor, for just explaining a little bit more about you. And you were talking a little bit about mentorship. And I just wanted to ask, how does your strong passion for mentorship manifest in your present role? Could you probably describe the ways in which you are currently applying mentorship to guide and support other developments of junior colleagues?
So first of all, I would say that I have always been clear with myself and with my mentors about my interests. And that was always important because what that meant was that on our path, their path in helping me and my path in developing my own professional expertise and career, there was always clearness in how to succeed. It was not unclear to me in what I needed to do. I needed to work hard. I needed to be creative. I needed to be thoughtful. Always, by the way, behind all of this was excelling in clinical care. So I think one thing I will say, just for anyone who's listening to this, that's sort of in the process of applying to college or medical school or residency or fellowship, before you can become good at anything in research or professionally, you have to be an excellent clinician. And people that I looked up to as an intern, actually, it happened before that, probably in medical school, but really as an intern in my residency program at Albert Einstein College of Medicine and Montefiore Medical Center in the Bronx, really instilled that in me. The importance of being an excellent, not just a good, but excellent clinician. Everything else comes from that. So that's one important piece I think I have to say. The second piece is finding good mentors is hard. Being a good mentor is really hard. And I think for me, I have been lucky to find great mentors. My current mentor, the head of the leukemia program, Dr. Gail Robos here at Cornell, who has been involved in mentoring since I was a fellow here. My mentor from residency, Dr. Amit Verma, who's an MDS specialist. I've just gotten very lucky, and it's not just me. I of course I did research and I thought about who and where I would be with, but I have been the recipient of good luck in that way, that these mentors have been particularly amazing in guiding me forward. But as far as from moving forward, I've learned from those experiences is the importance in serving as a mentor, as I've done, to pre-med students, high school students who have clinical research or translational research interest, residents and fellows. And I have served in several roles spanning from high school students all the way to fellows as a mentor. And I have used the things that I have learned as being a mentee to the things that I thought were great, the things that I thought could have been done better, to really hone my skills as a mentor. And that's actually one of the things that drive me now. I am an academic. I'm at a large academic institution. I'm the director of the inpatient leukemia service. I am the assistant director of the hematology and oncology fellowship program. I have a lot of roles, and some of them administrative, some of them clinical. I also do clinical research, but I have a very, very strong, strong drive and feeling of importance of the mentoring and education of students and trainees to be the next generation of doctors, because I feel it's important that they develop the same skills and maybe even do it better than my generation did, so that they become the next leaders and excellent clinicians and expert clinicians in these fields. And so I feel a very strong sense of giving back in that way, and I credit that to my mentors throughout training.
Okay. You, Dr. Kanner, have a very strong passion for mentorship. So who would you like to attribute as your role models?
Who are my role models? That is a hard question. Um, I've never actually been able to answer that question successfully, because I find that I've had too many people, like non-significant people, I don't mean to say non-significant, people that are not famous, people that are not senior. I've just generally been have surrounded myself with good people throughout my training, all the way back from medical school all the way to currently, who I've taken the things, the attributes, the values that I felt like were strong and important to follow, and let that rub off on me a little bit. And I don't think there's any one person. I think it's a collective. And I think that it's a great question. I think there are probably people who could say, oh, I have this role model. For me, I kind of look at everybody I've worked with that are either colleagues, peers, seniors, mentors, and sort of let the values and attributes that I see as being particularly important to their career development and their value system as a human being, as a clinician, and sort of letting that rub off onto me. And I think that's led to me succeeding in my professional development. And again, as you mentioned, being able to mentor others and continuing to be passionate about it. I'm very busy. I have a lot of patients. I do research. I have my hands in a lot of different things, but I still have the passion for education, for teaching. I teach the medical students. I volunteer my time to high school students for research mentorship for their clinical research or translational research courses that they take. So I feel very strongly about that and giving back.
Thank you, Doctor, for that wonderful synopsis. Of course, it's very hard to choose who's your role model, but as you said, it's an experience and everyone pitches in to make your success as it is today. And then just for our last question, for our more junior attendees just getting into research in medicine, what inspired you to pursue the field of oncology? How has this choice impacted your life? And has it been truly everything you anticipated?
So I think what's interesting about my trajectory to where I am today is I found that a lot of people, a lot of peers, and even colleagues probably had very strong reasons to go into medicine or strong reasons to follow a specific specialty. I have been driven by genuine interest in the biology of this disease, in particular leukemia. And that's what I mean by at every step of the way. I don't know if it's because of what happened when I was a child or if I just really enjoyed learning about this disease, but I have felt that I've been driven by an interest in a biological interest in this disease. And as I've learned more about it, it only built and built and built to a point where I saw a problem that needed to be fixed. Now, I'm not fixing any problem. I don't mean to suggest that I'm fixing a problem. What I mean is that this is a field in which there has been dramatic improvement, but there remains a lot to be done. And it is a hard, challenging job. Patients are sick when they come in. Our job is to put them into remission, get them on their way to eventual cure. I have felt that as far as I can tell, my experience is anytime I came back, whether I was on like in internal medicine residency, whether I was on like a general medicine rotation and did an elective in hematology, or I was on hepatology, which is liver transplant service, and then I came back and did a solid tumor oncology elective. Anytime I came back to anything hematology oncology related, I just felt so passionate and driven and intrigued and interested. And more important than that, I have always felt a connection, deep connection to the patients. This goes back to my first patient interactions with pediatric leukemia patients when I did an elective as a third year medical student. I just always felt a deep connection, and I don't know why. I can't put my finger on it quite put my finger on it, but I have found ease in communicating with people who are having a difficult time. And you combine that with an interest in the biology, and then this challenging work environment, and the fact that this disease remains highly fatal for too many patients. It's sort of for me, a perfect specialty. Now, to your last question, it's been more than what I would have expected personally. I didn't necessarily know where my career would lead me, but where I am today, starting my 5th year as an attending, as where I'm currently spending my 8th year at Weill Cornell Medicine, running our inpatient leukemia service, being involved in the fellowship program, mentoring and teaching, all these things have been way more than I could have expected or wanted. And I'm extremely happy, and motivated to continue pushing forward with this. And I can't attribute it to a specific decision I made other than just following my passion and just following my interests, and letting that guide me to where I am, saying yes to things that I wouldn't ordinarily say yes to, working really hard again, and just to sort of bring it full circle, having excellent mentors to guide me.
Thank you, Dr. Kanner. It was a pleasure learning from you and about all your important work. How can our audience connect with you?
That is a good question. So I actually, I often am active on Twitter. I have a Twitter handle. I just refuse to call it X, but my Twitter handle is jkanermd @jkanermd. You can email me. You can connect with me on LinkedIn. Any of the social media sources are fine. My email is jdk9007@med.cornell.edu. I'm happy to interact with anybody and have further discussions. And this is a field I love, I'm passionate about, and thank you for having me.